So that's what. And that's what Caitlin is gonna talk about. Excuse me. I just wanna make sure that everyone understands how we're gonna run things today. So Caitlin has a presentation. She's gonna go through her presentation. Please do not interrupt her presentation with questions. Let her get through the entire presentation. After that, we'll take questions. We'll take questions from people in the audience here, and then we will turn and take questions from people that are online. If for some reason we see some reason to interrupt, if there's a question that is super pressing online, we'll let Caitlin know. Okay. So we'll turn it over to Caitlin and thank her for coming today.
Hi, everybody. Thank you. So my name's Caitlin Parisi. I work with a company called Medicare Resource Group. Been working with RSS for, I think, close to 10 years now, and assisting all, members with their Medicare questions, or, helping them sign up for Medicare, federal Medicare. So I'm a free resource. If you want to pick my brain and you have a question, just please don't interrupt during the presentation. I will answer any questions you may have after. You'll notice there's a blank piece of paper I attached there. That is for you to write down, any questions you have, or take notes. So I'm just gonna go to the.
Yeah, because then people online can see.
Okay, let me. So this is about the 2026 changes to Medicare. This is not a marketing presentation. So if you ask me about a specific company, I am not going to talk about a specific company. So this is all educational in relation to Medicare. Okay. Hold on a second. So again, this is my information, and if anyone has a question, my job really is, in the long run, is I help advocate for my clients. So that's facilitating or escalating problems between, that you may have with the insurance company, looking for subsidies, grant programs, as well as finding a plan that meets your needs. But really, my job is much more advocating in the long run for our clients. So if you do have a question, please feel free to pick my brain. Okay, so we're going to discuss in this presentation the 2026 changes to Medicare, the 2026 Medicare premiums and amounts. And I just want to let you know, we do have a government shutdown right now, supposedly happening. The amounts should have formally been released after Election Day. They have not formally been released yet, which means like the Medicare Part B premium for next year. But we have estimates, and the estimates usually are always very close. Once I get the official amounts, I will update the RSS and they'll put it on a bulletin or have a blurb with the official amounts, but these are very close estimates. The 2026 changes to Medicare Part D we're going to discuss as well. Some of the New York consumer protection laws that benefit you. So if you live in the state of New York, you need to know that New York State has some of the best consumer protection laws that protect you, the Medicare beneficiary. Okay. The pros and cons between Medigap, also known as a Medicare supplement, and a Medicare Advantage plan. Those are the questions I get asked the most. What's the differences? What are the pros and cons? So this is going to be a little bit of some Medicare 101 just to refresh your memory. And then we'll go into some of the changes. And I also am going to talk about New York Epic, which is a great state pharmaceutical assistance program. Okay. So I just want to refresh, because many of you over the years have been to my Medicare 101 presentations where we talk about Medicare Part A and Medicare Part B. That would take another presentation for me to do, but I do want to do a quick refresher just to refresh anyone's memory. But traditional Medicare, also known as original Medicare, is a federally sponsored health program that you paid into throughout your working history by paying FICA taxes, right? Medicare Part A is premium free so long as you or your spouse work 10 years on the books, right? So as long as you or your spouse have paid into that system, Medicare Part A is premium free. Okay, it covers your inpatient hospital, skilled nursing care, home care, hospice, as well as other services. There's co-insurance and deductibles involved under Medicare Part A, and it's not 100% coverage, but it covers those services. Now, Medicare Part B, which is all your outpatient services, that's doctor visits, outpatient surgery, lab, MRIs, and so forth. Everyone has to pay a premium for that, okay? Everyone has to pay a premium for that unless you have Medicaid or some type of subsidy or maybe a benefit through a former employer like a retiree plan. Pretty much everyone has to pay for Medicare Part B, okay? And Medicare Part B covers 80%. And you, the beneficiary, are responsible for the 20%, or you have some kind of supplemental insurance to pick up that 20%. Okay? So that's just bare bones Medicare, right? Doesn't pay 100%, but 80%, okay? And you're responsible for 20%. And co-insurance and deductibles. There is no cap on traditional Medicare. So what that means is if I spend, let's say, $20,000 a year in medical expenses on my end for, let's say, chemotherapy or what have you, there is no, oh, Caitlin, you spent X amount of dollars this year. Traditional Medicare will now pay 100%. Traditional Medicare does not cap your out-of-pocket exposure on the 20% or the Medicare hospital Part A deductibles, skilled nursing co-insurance, okay? So this is just regular bare bones traditional Medicare. We haven't added anything to it yet, just regular Medicare. And I just wanted to refresh everyone in case you weren't sure what traditional Medicare is. So right now, most of you are paying the standard rate for Medicare Part B, which this year was $185 a month. They anticipate for next year, the Medicare Part B premium will be $206.50 a month. That is the estimate, okay? Usually the estimates are always very close. So you might see it vary by a few dollars, but that is what the estimate is from multiple think tanks. And so this is what we're likely going to see for 2026. Okay. Yes, it is a jump. It's a jump of about $2,150 from 2025. Now, right now, the Medicare Part B deductible for this year is $257, right? So that means, you know, if you have traditional Medicare, you have to reach that deductible first for any diagnostic related services, not preventative diagnostic, meaning if you're seeing a cardiologist, if you're seeing dermatologist, right? If it's not part of your yearly wellness or like a preventative screening, then you're subject to that deductible. And what that means is you have to pay that deductible before Medicare Part B starts paying 80%. This year, it's $257. We anticipate next year it will be $288 for 2026. That is what they're estimating, okay? We don't have the IRMA thresholds yet, but there's estimates. It's going to be, right now, I believe you pay the standard rate for your Medicare Part B premium in 2025. If you're single and your income's $106,000 a year or less, you pay $185 a month. If you're married and your income is $212,000 a year or less, modified adjusted gross income, they look at 2 years prior, you pay the standard rate of $185 a month. They do up that threshold every year. So we do anticipate it'll likely be raised to, I don't know why there's a 1 there, but likely to 218. So for next year, we anticipate if you're above 218,000 as a married couple, you're likely going to pay more for your premium. Okay, so there are people who pay more for their Medicare Part B premium because they are in a higher income earning bracket. Most of you pay the standard amount, but if you're in a higher income bracket, you do have to pay more for your Medicare Part B premium. Okay, so this is what the estimation brackets are for IRMA. Again, I'm going to have the official numbers likely. I'm hoping Medicare will release them next week. And once I get the official numbers, I will definitely, you know, anybody wants it, I will send it to them, okay? So this is what they're anticipating. I don't know why they have this here for Part B. But as you may know, you have Part B IRMA and Part D IRMA, okay? So I was hoping that by today, I would have the official numbers for Medicare, because normally the numbers are always released right around Election Day, but they have not released the official numbers yet. So again, these are estimates, but they are close estimates, okay? If you look at the 2025 IRMA brackets, you could see that these are close estimates. But again, if you're in a higher income bracket, you can see that you will pay more for your Medicare Part B premium, right? And you also have to pay what's called Medicare Part D IRMA as well. So it's IRMA for your Part B, which is your medical, and Medicare Part D, which is your prescription drug coverage, okay? It's very common for people when they retire to be hit with IRMA because they just left the workforce. Just know it is reevaluated every year by Social Security, okay? Okay, let me just get that out of the way. Okay. All righty. Okay. So again, this is if you just had bare bones Medicare. Right now in 2025, if you are, oh, what happened to my presentation? Who did that, Barbara? It's all right. I don't want to mess with the,
I got it.
I'm not the best at tech.
But she's very good at insurance, so we're gonna, oh, okay, never mind. I know what I did. Okay, my bad.
You have to do it in there?
Yep, hold on.
No worries.
You look good.
Thank you. I will say,
Doesn't she?
thank you.
Then we're just trying to show her off.
Ah, thank you.
All right. Up. Here, let me share, and we're back
Yes,
here,
right
and we're
there.
back in business.
All right. All righty, so again, if you had bare bones Medicare, your red, white, and blue Medicare card, and you were admitted into the hospital in 2025, you would have to pay a $1,676 deductible the minute you are admitted, okay? You're admitted. Well, you're not going to pay it right. They're going to bill you after the fact, but trust me, they're billing you right. You know, they know what you got to pay. So I wouldn't be surprised if eventually, with the way things are going, we're going to have to pay right when we're in the hospital. So yeah, $1,676 deductible is what the number is for 2025. The estimation is it's going to be $1,716. Now again, that's if you just had Medicare by itself. There are some people that do it, but that's if you just had Medicare by itself. That's what you would pay for the first 60 days you're admitted. And if you go beyond day 60, you'd have to pay $419 per day, days 61 through 90. These always fluctuate by a few dollars each year. But again, if we saw this during COVID, there were people who were in the hospital for a long period of time. This is what they would pay under traditional Medicare. So you'd pay day 61 through 90. You'd pay, $14,246 under traditional Medicare only. If you went over that, Medicare does give you something called 60 lifetime reserve days, where you'd have to pay $838. By that point, you'd pay almost $64,000, and then after that, you'd be responsible for all costs, right? So this is just if you had traditional Medicare only, you didn't have a supplement. And this, again, they up it a little bit each year, okay? But most of you do have either a supplemental or maybe you have a Medicare Advantage plan, okay? But if you just had bare bones Medicare, this is what you're gonna pay. Now, if you are under Medicare Part B and you don't have any secondary of any kind, you have to pay 20%. And where that can leave people vulnerable is definitely cancer, chemotherapy, immunotherapy, because there are treatments, especially if it's chemotherapy, you're looking at, that 20% could run you $600-700 per treatment, right? And if you have to do, let's say, 15 chemotherapy treatments, that is where traditional Medicare can become a little expensive, right? There are some gaps in it. The 20%, in my opinion, for doctor visits really doesn't come out to much from what I've seen. But again, this is what you'd pay if you just had traditional Medicare only. If you see that 15% in the far right corner, there are providers out there who may not take Medicare assignments, which means that they don't agree to the Medicare rate for services, and they can bill what's called a Medicare Part B excess charge. So for example, if you and I go to the primary care doctor and we both do the same thing, but I have commercial insurance and you have Medicare, we go for our wellness visit or what have you, my commercial insurance is likely going to pay that doctor $300, let's say. But since you're on Medicare, the rate is negotiated. The doctor's going to get probably $150 for the same visit. So Medicare negotiates costs, and costs are always lower. If you ever look at your statements for Medicare, you'll see provider billed the plan $5,000 or some number, and then Medicare adjusts it to the allowed amount of like $500, right? That's the Medicare rate. Okay, now there are providers who don't agree to the Medicare rate, and they are allowed to bill what's called the Part B excess charge. And they can bill 15% above the Medicare rate. So let's say for a primary care doctor, the Medicare rate for that visit is $100, let's say, but that doctor doesn't agree to Medicare assignment, the Medicare rate, they could bill $15 on top of that. Now, this is not something you're really going to encounter in the state of New York, and I'll tell you why. New York is what's called the Medicare overcharge measure state, meaning that we limit the excess charge to only 5%. And from what I've seen, you're bound to run into it with some of the podiatrists and individual self-employed psychiatrists. Very common to see it with those specialties, but if you're using Major medical systems like Columbia Presbyterian, Well Cornell, Mount Sinai, Lenox Hill, Montefiore, Memorial Sloan Kettering. For the most part, those facilities do take Medicare assignment, and a lot of providers in those facilities do take Medicare assignment. There is a percentage that don't take Medicare whatsoever, and if you want to see them, Medicare is not going to pay at all. So there's about 94 to 95% of providers that take Medicare assignment, and there's a percentage that will take Medicare, but they don't agree to that assignment. You could see those providers, but you're going to pay what's called an excess charge. And then there's a percentage that has opted out entirely, which means you can't see them at all. They've opted out of Medicare entirely. And for those doctors, you'd have to pay the full retail cost, whatever it is they're charging, because neither Medicare nor a secondary is going to pick that up. Okay? All right. And don't worry, I'll have some slides that talk about it more, in case you're a visual. Okay, so skilled nursing care. This is definitely probably the most common cost-sharing risk I see my clients run into who are on traditional Medicare. Cancer is a big one, and so is skilled nursing. As you get older, we all know things start to change. Orthopedic issues, things start to, obviously, things start to break down a little bit as we age. So this is what you would pay if you had traditional Medicare only and you were admitted into a skilled nursing facility. So for the first 20 days, I wouldn't pay a copay. But after day 21, I would have to pay a copay. For 2025, it's $209.50 per day, days 21 through 100. I would be paying almost $17,000 for a 100-day stay in a skilled nursing facility on traditional Medicare only. And that is most definitely a very common potential risk that people will, incur as they get older. Because as you get older, something happens, you fall, you break your hip, and you need to go into an inpatient skilled nursing facility to recover. It's likely that you might need 60 to 70 days in that facility. So this is, what the cost would be under traditional Medicare only. If you had a Medicare Advantage plan, for instance, if you guys ever saw on your Advantage plan, maximum out of pocket, $9,000, that means that, if you're on an Advantage plan and you're in one of these facilities, well, you'd likely pay $9,000 max on your plan's maximum out of pocket for a 100-day stay. And then your Advantage plan would pick up, 100% after you've reached the maximum. But if you just had traditional Medicare only, this is what you'd pay. $16,760 in 2025 for a 100-day stay in a skilled nursing facility. For 2026, it is estimated it's going to be closer to $218 per day, days 21 through 100, for a skilled nursing facility stay, okay? So most of you have a supplemental that, a Medigap plan that picks up that co-insurance, or you have an Advantage plan that protects you with a maximum out of pocket. Okay? Okay, so this is again what the Part B deductible estimate is. We estimate $288. That is what the estimate is. So if this is what you would pay, your 20%. A lot of preventative screenings are covered under traditional Medicare. Traditional Medicare by itself doesn't have prior authorizations, but there is coverage rules, right? There are certain tests you can only do through a preventative test that you could do during a certain time window. I'll give you an example, like lipid panels is something that Medicare covers as preventative every 5 years. However, if you're someone that needs to do it more often because you have AFib or some type of, you have artery disease or something like that, then you can do so, but it's going to be billed as a diagnostic test, okay? So there's rules with the frequency of what testing you can do under traditional Medicare. But again, you are responsible for 20%. If you do not have a supplemental or some type of managed care plan or a retiree plan through a former employer. So again, if you went through chemotherapy under traditional Medicare and you just had the Part B and your chemotherapy bill all said and done for your 15 visits was $100,000, you would be paying. The $20,000 would be your responsibility, right? Because traditional Medicare by itself does not cap you on your out-of-pocket exposure. Obviously, because there are holes in traditional Medicare. Oh, is there a little feedback here? So obviously, there's some holes in traditional Medicare. As excellent and comprehensive as it is, there are holes in it. So maybe you get what's called a Medicare supplement plan, also known as a Medigap, to fill in the gaps, right? To make your Medicare, which is right around 80%, closer to maybe 100%, right? So these are the plans you might look at. Now, if you turned 65 before January 2020, you can purchase Medicare, Medigap Plan C and Medigap Plan F. Okay, those individuals can still purchase it till this day. But anyone who turned 65 on January 2020 or had Medicare January 2020 onward cannot no longer get Plan C or Plan F. So only if you had Medicare or turned 65 before January 2020 can you get Medicare Supplement Plan C and Medicare Supplement Plan F. And just so you know, Medigap and Medicare Supplement are the same thing. It's synonymous, no difference. So really the most common ones people go to is Medigap Plan G and Medigap Plan N. So when people look at these plans, when they're looking at supplement plans, it's sometimes a foreign language to them because many of you are used to having work insurance where there's a $50 copay for the specialist and everything's broken into copays. On a Medicare supplement plan, it doesn't work that way. You have to look at what Medicare costs to then understand what the supplement's going to pick up. So if I have a close to $1,700 deductible in the hospital under traditional Medicare, then I know these are the ones that are going to pay 100% of that Part A deductible. These are the ones that are only going to pay half of it or a quarter of it. Okay, if I go into, let me go back real quick. Hold on one second. If I, remember we were talking about how after day 60 on traditional Medicare Part A, you have a co-insurance for hospitalization, which could be quite a bit, or that co-insurance for skilled nursing care after day 20, well, these are the plans that are going to pay 100% of it, or half of it, or none of it, right? Some of them don't pay any of it. So that's how you have to look at these plans. When you're looking at it, you have to have what are the costs under traditional Medicare, and then these plans will tell you what they do and don't cover. Okay, but N and G are the most common ones because as you can see, they cover a lot of those gaps, okay? Alrighty. Any questions? Well, anyone have questions on this? Save it for the end. My apologies. Okay, so this is how a supplement plan works. And I usually have my little cards to do a visual, but it is the a la carte option. I heard a lady once say that, and I was like, that is the best way to describe this. Think about going to a restaurant and, you know those restaurants where you have to pay extra for the sides, you get your protein, and it's usually more expensive, but it ends up being a pretty good meal. That's kind of the way I would describe Medicare supplement plans, because you have to have 3 cards with you at all times, right? When you go to your doctor, the doctor bills your traditional Medicare first, the red, white, and blue card, and then your supplement is there to pay what Medicare doesn't pay for. Your supplement is just there to follow traditional Medicare. So for example, some of you may have heard United Healthcare Medicare Advantage is no longer going to be in network with Columbia Presbyterian starting January 1st, right? But if you have a United Healthcare Medicare supplement plan like FGN, that will not be applicable to you because Medicare, traditional Medicare is your network, okay? So this is something that can confuse people sometimes because a provider may not take United Healthcare Medicare Advantage, which does use a network, but they may take traditional Medicare. Okay, so if you are on the AARP Medigap plan, just so you know, the New York Presbyterian does not affect you, okay? So there is no network. Traditional Medicare is your network. Nationally, you can go to any provider in the nation. It was about 96%. I would say it might be 95% because sometimes the payments to providers can fluctuate under traditional Medicare. But go to any doctor in the nation that takes Medicare. Your doctor does have a bit more flexibility in managing your health care. Your out-of-pocket exposure is typically very predictable on a Medicare supplement plan, okay? The insurance company has no say over your health care, okay? So if traditional Medicare is going to pay for something, the supplement has to follow suit. If traditional Medicare does not pay for something, then neither will the supplement. It's very simple. You use 3 cards for everything, you pay 3 premiums. You always gotta make sure that you're showing your doctor the red, white, and blue card and your supplement card, okay? So this definitely works well for people who do have health issues or they're going to all these different doctors. It's definitely very good coverage, and your traditional Medicare, you're leaving it intact, okay? Okay, so these are some of the cons of supplement plans in New York State. So since we are a guaranteed issue state, meaning that we are one of the very few states in the nation that does not ask health questions. So some of you probably know this. When you go and look up general federal Medicare and Medicare 101, you'll see something that says you have a 6-month window to get a Medigap or Medicare supplement plan guaranteed issue. You have they call it the Medicare supplement open enrollment period, right? And what that means is in pretty much most states in the US, when you are first new to Medicare, specifically Medicare Part B, Part A and B, but specifically Part B, once that becomes activated, you have a 6-month window to get a Medicare supplement plan without any health questions asked. Once that window has ended, if you're not a healthy individual, they will not take you, okay? New York, we do not do that. We do not do health underwriting here. We are a guaranteed issue state. So that means that you could have every health issue, all these different health issues, they will accept you, okay? It's a great thing that we can do that because there are people who may do an Advantage plan at first and then move to the supplement later on when their health changes. However, they're quite expensive. So because of that, the premiums definitely are much higher in New York than they are in other states. I'll give you an example. With a January 1st, 2026 effective date, 65-year-old woman in North Carolina can get a plan N for probably less than $100 a month. Same company. That same woman, plan N in New York, going to be $299 a month for big difference. But it is a guaranteed issue. So we have very good protection laws here. What you're looking at again, you're looking at in the state of New York, if you did, and again, this is a Medigap plan that covers close to first dollar coverage, not 100%, but close to first dollar coverage. And depending if you're IRMA or not, which means you're in a higher income bracket, but most of you pay the standard rate for your Medicare premium. But you would have, between your Medicare Part B premium, your drug plan premium, and your Medicare supplement premium, on average, you're looking at least $540 a month, if not more. So it is expensive on the front end because New York, again, we're guaranteed issue, and it can be expensive for that person that lives on Social Security. It could be expensive, right? If I'm only getting like $3,000 a month in my Social Security and that's it, and a small pension, this could be very costly for me, okay? Medicare supplement plans do not offer ancillary benefits such as dental, vision, or hearing. Now, glaucoma screenings, going to see your ophthalmologist because you have macular degeneration, that's covered under Medicare. But doing like a routine eye exam with the optometrist because you want to get eyeglasses, that is not covered. Cosmetic dental is not covered, so if you need a root canal, traditional Medicare is not going to pay for it. And hearing is not covered for hearing aids, right? One of the cons too is that the supplement premiums can increase each and every year, and right now we are seeing 20 to 30% increases on these policies, in a lot of places actually. So it can be quite expensive if you're on a fixed income, right? So these are some of the cons. But again, if you're someone who does have a lot of doctors and you have a lot of health issues, your out-of-pocket exposure is very predictable because you're paying a higher premium up front, so you pay very little, you pay less when you're using it, you have predictable out-of-pocket costs. And again, you don't want to deal with networks because you can go to any doctor who takes Medicare. So there are a lot of pros, but there are also cons due to the pricing of how expensive it can be. Okay, and again, as I said, New York is a mom state. We have Medicare overcharge measure protection laws, which means that protects you from being overcharged by a provider who may not agree to Medicare assignment. Okay, so if you want to know, Medicare supplement plans are regulated by the state of New York. They're not regulated by federal Medicare. Medicare Advantage plans and the drug plans, they're federally regulated. The supplement plans, also known as Medigap plans, like Plan F and G and N, they are regulated by the New York State Department of Financial Services. And New York is the one that regulates it, okay? So we are a guaranteed issue state for these policies. However, there is only one limitation in New York. So if you're on traditional Medicare only and now you get cancer or something and now you want to get a Medicare supplement plan, you could do so, but they're going to institute a 6-month waiting period before they pay out for that and cover your pre-existing condition. So New York knows this. So if you're on an Advantage plan and you consecutively switch to a supplement, or you're on one supplement plan and moving to another, the waiting period's waived entirely. Okay, so this is why we tell people, if you just have traditional Medicare only, and you want to do that for some time, and you don't have a supplement, or you're not on an Advantage plan, or have some type of retiree coverage, you are potentially putting yourself at risk, right? All right. So if you have questions for that, please save it for the end. So let's talk about Medicare Advantage. So we know that there's a lot of great things with the Medicare supplement plans. We also know they are quite expensive. So, you know, maybe you're going to do, or you are on a Medicare Advantage plan. You're still part of the Medicare program. However, you now have a private insurance company that's coordinating your Medicare benefits. Okay. So essentially what I tell people is it's like you're taking your red, white, and blue card, so to speak, and you're putting insurance company's name on it. So now let's go back to the restaurant, right? I said on Medicare supplement, it's like the a la carte option. You're adding your sides. You have to pay extra. You tend to pay more when you go to an a la carte restaurant. Now we're going to do the all-inclusive option, where everything's, you know, part of the meal. You get your sides built right into the you know, your entree. Medicare Advantage is like the all-inclusive option, right? You use one card for everything. One card for the doctor, one card for the pharmacy, one card for the hospital. Your red, white, and blue card is essentially dormant. You're putting that in your back pocket in case you need to change your coverage down the line. But if you tried to use your red, white, and blue Medicare card while on a Medicare Advantage plan, it's not going to work, okay? So most Medicare Advantage plans have a very low premium or a $0 premium. You still have to pay your Medicare Part B premium each month regardless, or if you have a subsidy of some kind. But a lot of them are affordable on the front end. You essentially pay as you go. It looks very much like work insurance, right? If you were employed, you know that there's co-pays, and you know you have to pay those co-pays. That's basically what Medicare Advantage plans do. They basically essentially take the 20% under traditional Medicare and they break everything down into co-payments, and you're protected with the maximum out of pocket, okay? So you have that maximum out of pocket that protects you. It's not a deductible. A lot of people confuse it with a deductible. It's not a deductible. The insurance company is your accountant. Every co-payment that you're paying gets accounted for towards that maximum out of pocket. And if you reach that maximum out of pocket on your plan, they then pay 100% until the remainder of the calendar year. And then it restarts all over again come January 1. So this is not a specific plan. This company doesn't exist, but this is just to give you an idea of what a Medicare Advantage plan will look like, okay? You have co-payments for everything, right? This is what the benefit structure looks like. And this is very commonly what the benefit structure and the co-pays are in this ballpark for New York City and Bronx residents. So this is, people always confuse this with a deductible. It's your maximum out of pocket. The insurance company's covering you when you go to the doctor or get outpatient surgery or do whatever it is you're doing, but they're not paying 100%, right? You're paying a share and so are they. And then if you reach $9,550, for instance, on this imaginary Advantage plan, they then would pay 100% of your medical costs for the remainder of the year. It's an HMO. You can't go out of the network, obviously. On this plan, you have to stay in the network. If you are on a PPO Medicare Advantage plan, this is what it would look like, the benefit structure. Obviously, it's in your favor to stay in the network because you pay lower co-pays. If you go out of the network, you obviously pay more, right? So the maximum out of pocket, just so you know, on a lot of the individual plans, they're usually for out of network, it's somewhere between $13,000 to $14,000 what we're seeing for out of network coverage on a Medicare Advantage plan. So you pay as you go. The insurance company is your accountant. That is how Advantage plans work. Okay, so if you have, you have some medical issues, but you're relatively overall moderately healthy, you're on a fixed income, yeah, it works, may work for you. There are Advantage plans that do have very good ratings and have a good network, right? You always have to look at the ratings and the network and so forth, but there are plans that do have very big networks in New York. But yes, these you have copay responsibility. Now let's talk about some of the cons of the Advantage plans. So we know that they are affordable on the front end. A lot of them will offer ancillary benefits like some dental, vision, or hearing, right? A lot of them are gonna have the drug coverage built in, so it can be very affordable on the front end because you're paying very little in premium aside from your Part B premium every month. However, here's the cons of a Medicare Advantage plan. In most cases, you do have to use a network of providers. So if you're on a traditional HMO, even if the provider may take Medicare, if they are not in network with your plan, you cannot see them if you're on an HMO. You're gonna have to pay the full cost. So you have to stay in a network when you're under a Medicare Advantage plan. Right, so there can be some network limitations, depending obviously on where you live, but there can be some network limitations. A Medicare Advantage plan that is a PPO, where you have the out-of-network coverage, you know, you can go to a provider out of network on your PPO that takes Medicare, but at the end of the day, it is still up to that provider if he or she wants to accept your plan and bill directly. You may have to pay up front and then submit it to the plan for reimbursement if you're on a Medicare Advantage plan. So this is the big one. Because you pay as you go, you have co-payments for every service. In the event your health changes, costs can start to really pile up, right? So if you're seeing several doctors a month, or you're doing physical therapy twice a week, which could be a $40 copay on a Medicare Advantage plan, that can become quite expensive, okay? So expensive treatments can cause a member to hit their maximum out of pocket, which can be very stressful, seeing all these bills come in. So if you are someone that does have a lot of health problems, a lot of health issues going on, an Advantage plan may not be the right fit for you, okay? Prior authorization rules. So Medicare Advantage plans do require prior authorizations for certain services. MRIs, CAT scans, if you're doing an elective surgery, it's going to require a prior authorization. This could be frustrating if it's something, you know, that's not an emergency, but, you know, has become maybe urgent. You need to do, orthopedic surgery. The plan might say to you, we're not going to approve it first until you do 15 physical therapy sessions, and then we'll decide if we're going to cover it or not, okay? There are prior authorization rules, okay? If it's a medical emergency, there is no prior authorization, obviously. There's no prior authorization for that, but, you know, there are prior authorization rules, and as people age, and, you know, if you're well into your 80s and 90s, you know, those prior authorization rules could become annoying, okay? Especially if you're starting to utilize a lot of healthcare services. Statistically, they say, Kaiser did a study on this, most people, now some people have health issues right out the gate when they turn 65, but most people, you know, are not utilizing their Medicare to the full extent until they start approaching their mid to late 70s, well into their 80s. So from 65 to 75, those really are your golden years for many people, where they may not be utilizing their insurance that much. But as you get older, eventually you will, okay? So I just want to be aware of all the marketing that's going on. I know that people get emails and calls and mailers. My mother even gets calls, and they say they know me. I mean, which is crazy. I don't know who these people are. I mean, that's how desperate they are, you know? But, you know, I get so mad at this stuff because they make it look like it's official and coming from the government. It's not. It's marketing. It's marketing, right? I can't tell you how many times people have asked me about a flex card. Or right now, you know, there's those deep fakes on Facebook. You might see like someone that looks like Joe Biden or Donald Trump saying you're going to get all this money put back on your Social Security check if you call this number. It is all marketing. A lot of it is not compliant. So if you're getting bombarded with calls every day about Medicare, just know that they're not supposed to do that or solicit you. I know that it's gotten a little bit better. I don't know if everyone's still getting bombarded with calls. I've still gotten them. Yes. Next time, ask them for their NPN number. That's National Producer Number. Use that terminology as if you know. That's basically what it's like. Kind of like an NPI that's similar to a doctor. It's insurance. We all have what's called NPN numbers, National Producer Number, and they have, in order for them to, you know, even work with the Medicare companies, you have to, or, you know, the insurance companies, you have to have an NPN. Ask them what their NPN is and who their upline or FMO is. Use that. That's insurance terminology. From what my clients have told me, when they say that, because your information and data, believe me, is being resold all the time. It's called, they're basically lead aggregators. They're companies that sell your data to, you know, insurance companies or brokerages or what have you. And if you start using that terminology, they may update you in their profile and say, don't call this person, might be a secret shopper. Medicare does have secret shoppers that look to make sure that agents are being compliant. So if you do that, you might really see that the calls stop, because they might get nervous and think that you're, so just, because I know how annoying it can be. But next time, ask them for that, and I guarantee you they're going to hang up the phone immediately when you ask that. But yes, there's no flex. Again, there's people who have Medicare and Medicaid that may qualify for some of these advantage plans that offer like, $150 to $200 a month or what have you, food, over-the-counter utility card. Most people do not qualify for that. So I know there's commercials and there's mailers that make people feel like they're missing out, possibly. Just understand that many will not qualify for that unless they have Medicare and Medicaid. So just be wary of the marketing during this time of the year, because really a lot of it is incentivized to get you to call and then to do a bait and switch. And, there are people in this audience that might have a retiree plan through, GHI, they worked for the city or were a teacher. And I've had many come in, they'll tell you, I've had people come in that are older and maybe, they're not as sharp as they used to be, and they fell victim to one of these, marketing ads, and it screwed up their, their plan, which was a great retiree plan. And it takes a lot of work to get them reinstated. So just be aware, if you have a retiree plan through, you're on GHI, senior care, or you worked, you were in a union, please don't, your coverage is very good coverage. You have a former employer funding it. You could really screw up your coverage by, in trying to enroll in one of these individual plans. So just be aware. People do fall victim to this, and it's very hard, and I've had to, help people try to get their coverage back. It's very hard to get it back if you do that. So be very wary of the phone calls or items you receive in the mail during this time. Okay, so Part D, which I think is always been a thorn in my side, and I think for everybody. Some of you probably know we used to have what was called the donut hole. Does everyone remember that? Remember, like, in the beginning of the year, you'd have your deductible, and then like June would come, and all of a sudden, if you were one of those people taking an expensive drug, all of a sudden you'd go to the pharmacy and it was like $200 to $300 more. You were like, what happened? So we used to have, as many of you may know, we used to have it where you'd have like a bucket of money you could use to pay for your prescriptions between what you would pay and the insurance company. They would call it the initial coverage limit. It would be like $5,000 or $6,000, and if your drug cost exceeded that, then you'd fall into the donut hole. That doesn't exist anymore. They got rid of that, so there is no donut hole anymore. We don't have that. They eradicated that, I think, or got rid of it in 2025. That's still not to say that you won't pay, quite a bit for your prescriptions. So for 2025, we know that everyone was capped for their Part D at $2,000 individually. For the individual plans. Now, if you have a retiree plan, they may have it different. Usually it's less if you're on a retiree plan. But if you have to get an individualized plan, your out-of-pocket for 2025 was $2,000. So that means for prescriptions. Between your copay and what the insurance company pays in prescriptions, right, if you exceeded $2,000 on your end, then they would pay 100% of your prescription costs for the remainder of the year. There was some plans that were enhanced where they would calculate it a bit differently. But for the most part, you're capped at $2,000 on your end. Prior to that, it was like an $8,000 number. It was much higher. So this is a very good thing. And this was thanks to the Inflation Reduction Act. For 2026, you're going to be capped at $2,100. Okay, so that's what the cap will be, which is your out-of-pocket threshold. So that means if the drug is on the formulary and it's covered, you can pay no more than $2,100 for your prescriptions for the calendar year. And then the insurance company will pay 100% until the remainder of the calendar year. 2025, the deductible was $590 or less. Medicare sets a blueprint, okay? So for next year, many plans have a $615 Part D deductible. For drugs that are usually our brand name, right, like Eliquis and Entresto. If you're one of those people that takes like a losartan or metoprolol or those statins, those usually are inexpensive drugs. Usually you don't have a deductible. But if you are on like a biological or a brand name drug, yeah, you're likely going to have a deductible. But Medicare sets the blueprint. 'Cause you will not see an individualized Medicare Advantage plan or a standalone drug plan that has a $9,000 or a $900 deductible. It will either be $615 or less, okay? Now, each drug plan, they are required to, at the bare minimum, they must cover 2 drugs per therapeutic category per Medicare guidelines. So that means that if I have high blood pressure and you have a thyroid disorder, the plan has to cover at least 2 drugs that treat my high blood pressure and your thyroid disorder, right? So they must. Now, what will vary are the cost can vary from plan to plan. And all drug plans are categorized into tiers, T-I-E-R-S, tiers. And most of the time they categorize them into 5 tiers. The higher the tier, the more I'm gonna cry, okay? More tiers, higher tiers, because I'm paying more money. So yeah, usually, 5 tiers. If you're someone that takes a biological, any drug that's self-administered that you have to pick up at the pharmacy, that falls under Medicare Part D, right? Anything you're picking up at CVS, Medicare Part D. Now, if you're someone who does infusions, like in a doctor's office setting, where a doctor needs to administer the drug, in most cases, that's gonna fall under your medical, okay? Part B, correct. Okay? So this is what the benefit structure will look like, okay? So again, if you do take common prescribed generics, most of the time those are gonna be tier 1 or tier 2 where you have a copay, or you may not have a copay at all depending on the plan. But if you are one of those people that takes brand name drugs or specialty medications, yes, they're gonna be expensive. And not every plan will cover those drugs, right? Because they are required to cover 2 drugs per therapeutic category at the bare minimum, but one plan may not cover your drug versus another, okay? And I know a lot of people are taking Ozempic right now, and that's usually a tier 3 drug, right? But this is the benefit structure, so you're capped at $2,100 for next year for your Part D. Okay, so more and more we're seeing that the plans have a deductible of $615 or less for next year. January is not a fun month because some of you may know that's when you got to shell out that deductible, especially if you're on a brand name medication. If that is hard for you to do, there's a couple things you could do. You could ask the insurance company to put you on the Medicare prescription payment plan. You got to, I would ask them before January begins. And what they'll do is they'll break up those high copays into 12 monthly installments. So let me give you an example. If I take Eliquis, and in January I have to pay $615 plus whatever the co-insurance copay is on my plan, I can ask the insurance company prior, hey, I would like to be put on the Medicare prescription payment plan. And what that will do is they'll take those high copays and break it into 12 monthly installments. Now just keep in mind, each time you go to refill it, it's an interesting formula. You have to call them and have them check for you what you would pay each month under the Medicare prescription payment plan. But from how I've seen it, how it's calculated is 1 month it's low, 1 month it goes a little higher, then it goes a little higher, then they go up and down with the pricing. But it's kind of leveled out across 12 months. So it makes sense if you're going to do that in the beginning of the year. It doesn't make sense for everyone's prescriptions, but it may make sense for some of you. There are no fees, okay? If you are one of those people where you do, have a drug that's expensive, you can ask the company for what's called a tiering reduction. There's no guarantee that they're going to do that, but you can ask. There has to be, in a lot of cases, you have to have like a medical necessity as to why you need that drug, reduced in cost sharing. You have that right. But these are some of the ways to alleviate the burden, of shelling out all this money in January. You can ask to be put on the Medicare prescription payment plan, which would just kind of, alleviate some of that out-of-pocket exposure, except, over a 12-month period. Usually how it works is they're supposed to add it on top of your premium with the drug plan or and they send you a bill, or I think you can have it deducted. But call your insurance company if you're one of those people that does take an expensive drug and see how it would work for you. Okay, so these are what's changing for next year. I cannot talk plan specific or company specific, but I can tell you that we have less and less standalone drug plans than ever before. So if you are on a Medicare supplement plan and you have a standalone prescription drug plan, This year we had 12 plans. The year before there was 15. I remember when there was like 48 different standalone drug plans. We are down to 10 standalone drug plans for 2026. So there are less options than before with the standalone drug plans, okay? Some of you might remember we used to have drug plans that were like $3 a month or $6 a month. Those days are gone for right now. But we have less and less options. So I definitely would advise you call the drug plan up to make sure your drugs are covered for next year. Many of you have already gotten an annual notice of changes that's telling you what's changing for next year. Okay. Yeah, oh yeah. Everybody's, I think everyone, I think I've been calling everyone with bad news. I don't think I've had any good news for anyone this year. More Medicare Part C plans, you know, are cutting back on benefits. So if you're on a Medicare Advantage plan and, you know, you have over the counter or dental, we're seeing some plans making 50% reductions on the dental, meaning like if you had your plan had like $2,500 worth of dental allowance or insurance on your Medicare Advantage plan, we're seeing plans reduce it by, some plans by 50%, if not more. So there is a reduction in ancillary benefits we're seeing in dental, eyeglass, or, you know, they're charging, that we're seeing more Advantage plans charge a premium, you know, not that it's this high premium, but they're adding premiums to it. We're also seeing plans adding more medical deductibles. So if you're on a Medicare Advantage plan, you know, most of the plans for many years, you would just go right to the copay. You know, if it was $0 for your primary and $40 for a specialist, we're seeing more plans add like a $300 or $500 medical deductible for certain services. So just be aware of that, okay? We are also seeing dramatic increases in medical and hospital co-payments for the 2020, you know, for the Medicare Advantage plans. We're seeing, you know, them hike up the co-pays quite a bit. Because if you're on a Medicare Advantage plan, you know that they break it down into, you know, if you're in the hospital, $300 or $400 copay per day, day 1 through 6, and then you pay $0 beyond that. But we're seeing those costs really shoot up for a lot of plans. We're seeing that there's a large push from the insurance companies to kind of steer beneficiaries more towards the HMOs by making them a little more attractive than maybe some of the PPOs. We're definitely seeing that in the marketplace, so just be aware of that, okay? But this is, you know, we're definitely seeing that there's more of a push towards the HMOs. You know, I know a lot of people like PPOs, but we are seeing that more PPOs are having premiums or higher premiums or medical deductibles. So really look at your annual notice of changes. I know many of you do look at it when you get it, but there's a lot of people that just throw it in the garbage. Please check your mail, okay? So please read your annual notice of changes. I can't stress that enough, okay? If you are on a Medicare supplement plan, please expect your premium to increase upwards of 20 to 30% we're seeing across the board, really. Even in other states, they've shot up. And I'll tell you some of the reasons why. During COVID, a lot of people put their elective procedures on hold. If I needed knee replacement or hip replacement, it was put on hold because the system was inundated with COVID patients. And a lot of people are now getting those services and have been doing so for the last year and a half or so. So there's a large payout in claims with the insurance companies, especially the Medicare supplement plans, and it is causing a spike in premiums. I am hoping it will level out in 2027, because I remember, most of you may know, prior to the pandemic, if you were on a Medicare supplement plan, it was like maybe it'd be like a $4 or $5 a month increase. We're seeing some big jumps on a lot of the plans. Okay, so if you are on Medicaid or you are partially Medicaid, which is a QMB only, I could do a whole presentation on that. I'm not going to get into all the specifics. And you are on what's called a dual special needs Medicare Advantage plan, which is you have Medicare or Medicaid, or you have, you're a qualified Medicare beneficiary, which is partial Medicaid. You were receiving, if you were on one of these plans, most of them had the food card benefit with the utilities, where you could go to the grocery store or, go to pay your internet or something like that, right? It was just built into the plan. You were able to get it regardless of your health status. Next year now, in order to receive that benefit, if your plan offers it, you need to qualify. So it's called the SSBCI, which means Special Supplemental Benefits for the Chronically Ill. So if you do not have a chronic diagnosis, which there's a lot, blood pressure's on there, if you have high blood pressure, hypertension, there's a list of diagnoses that will qualify you. I think mental health is even on there. If you're at high risk for hospitalization, then you will be able to still receive those benefits. And the insurance company, for many of you that are members, they already know what prescriptions you're taking. So I see many that are they're being told that they're going to be able to maintain that benefit. If you have not received a notice of any kind, they may send you a questionnaire to see if you're going to qualify for next year. But if you are one of those individuals who doesn't have any, diagnosis and you don't meet the criteria, which I put it right here, these are you have to have one of the following: autoimmune disorders, cancer, cardiovascular disease, chronic heart failure, lung disorder, dementia, diabetes, ESRD, obviously, HIV, neurological disorders, severe mental health, or if you're at increased risk for hospitalization. If you don't check any of those boxes and you do have Medicare and Medicaid and you are enjoying that benefit, or you were partial, you're not going to be able to use it towards food for next year or utilities. I believe some of the plans may allow you to buy just your over-the-counter items, like certain toiletry products and vitamins, but you will be limited. So you're going to be impacted if you are one of those individuals, okay? They thought, Medicare had thought by, for people who are Medicare, Medicaid, that subpopulation, they thought by allowing people to buy healthier foods and making it a benefit on the plan, that it would reduce hospitalizations and that the risk group would be healthier, and they found that it really didn't change anything. So that's why they're kind of going this route instead, with the SSBCI requirement for next year. Okay. So just want to go over this real quick about New York. We have a pharmaceutical assistance program here called EPIC. It's an excellent program. It can help you if you are put on an expensive drug. However, EPIC, where I really want people on EPIC, if you qualify, if you are age 65 and over and your income, if you're single, is $75,000 or less, or if you're married and your income is $100,000 or less, you qualify for EPIC. And basically it works in conjunction with your Medicare Part D. But why I would want someone to have this is if you're on a Medicare Advantage plan and we're not in the enrollment periods and you call me and say, Caitlin, things just hit the fan, I need to get off of my plan because I want to go to HSS and they're not in the network, or I have cancer or something happen, and you now want to go on to that supplement plan with you got to get a drug plan. EPIC allows people a one-time special election anytime in the state of New York to change your plan once a year, and you can use it anytime. So it is a good tool to have in your back pocket in the event we need to get you out of your current plan. You need to get yourself out of your current individualized plan because something has changed in your health status. Many of you qualify, again, if you're married and your income's $100,000 a year or less, or if you're single and you're $75,000 or less, age 65 or over, you qualify for EPIC. But it is a very good program in the event you do need to change your plan, or maybe your plan doesn't cover a new drug that you were prescribed, where it's now, an exorbitantly expensive drug, and maybe you need to switch that plan to a plan that covers that medication. We don't know what's going to happen in the middle of the year, we don't know that. So this is good to have as a safety net in the event you need to get out of your plan, because this is the thing. Medicare supplement plans in New York are guaranteed issue all year long. They're open enrollment all year long, not a problem. The problem is drug plans are not open enrollment period all year long. And you need to obviously enroll into a drug plan, right, if you need to get out of your Advantage plan, and you need, the standalone drug plan is critical, because that is what's going to terminate your Advantage plan for the following month. You need to have EPIC in order to do that, right? So supplement plans you can sign up for any time of the year. The trick is you can't with the standalone drug plans. Right now, from October 15th to December 7th is the only time, if you're on a standalone drug plan, meaning you have a Medicare supplement with a standalone drug plan, this is the only time typically you can change your drug plan for January 1st. But if you have EPIC as well, you can change it if you need to, another time, outside this enrollment period. You can use it one time, any time of the year. If you're on a Medicare Advantage plan right now, which is any plan that's like an HMO or PPO individual, you can change from October 15th to December 7th. You could also change from January to March 31st. And you can also change if you have New York EPIC. So if you are one of those individuals, you technically could change 3 times a year if you wanted to, if you qualify for EPIC. So again, drugs now are capped at 2,100 for next year, and they're capped at 2,000 in out-of-pocket exposure for you. So most people, you know, that you honestly, if you're in a higher income bracket, yeah, it's not really gonna work for you unless you're, you know, in a lower income bracket where you just have to pay a fee and then it kicks in. But again, it's a good program to have, really, in my opinion, in the event you need to change your plan, whether it's your standalone drug plan because something changed, or you need to get out of your Medicare Advantage plan, okay, because something has changed medically or what have you, okay? So Epic, you could go right online, you just put in New York State Pharmaceutical Assistance Program, Epic. It can take you right to the hyperlink, and you could actually do the application right online if you need to, okay? All right, so how we can help people, you know, especially if they're signing up for federal Medicare, assist you and kind of guide you on what forms you need, can educate you on the different options in the Medicare market, research your doctors and medications. You know, again, I look at the whole person. We really do, I really am non-biased. Many people will tell you that. You know, the insurance companies drive me a little crazy with all these changes every year, but we work with them. We advocate on your behalf. That's really the biggest thing we do. See, helping you in doing an enrollment is the easy part. It's what you're going to be dealing with in your years on Medicare. That's where I come in handy, in my opinion. Kind of guiding you through some of that bureaucratic red tape that you might have to deal with if you're on an Advantage plan with prior authorizations. So again, if you are eligible for subsidies grants, we've tried to find those grants for people. One of my clients, you know, she couldn't afford the $300 a month Medigap plan, you know, for her cancer treatment, and on her Advantage plan, she had about a $7,500 maximum out of pocket at the time. She had cervical cancer. I knew she was going to hit the maximum on her plan because she was going to pay her 20% for chemotherapy and radiation. We found her a cervical cancer grant that paid the cost sharing for her chemo. So she got a $10,000 grant. So we will try to find you those programs if you're eligible. There are programs out there, and we'll find them, you know, if you're eligible. There's pharmaceutical, manufacturer programs for people on Medicare. They're not always easy to qualify for, but they're out there. So we will find you, you know, we will look to see if you're eligible for subsidies, grant programs, if you're eligible for Medicaid, okay? There is a lot of programs, and our services do cost zero because, yes, I am paid by the insurance companies, okay? Their Medicare does set the guidelines in place of what we're supposed to be paid, so there can't be, especially even with the Advantage plans, one company cannot pay more than the other. That's not allowed. I've heard probably 20 years ago it was different. I'm sure it was not good. I'm sure there was people being enrolled in plans that didn't serve their interest. This is my information if anyone has a question. This is my license with the New York State Department of Financial Services. That's my license, insurance license, and my national producer number if you want it, because I don't harass seniors like some of these bad actors. So I hope you got something out of it. I know this is a lot of information and it's hard to absorb. Okay. Yes. All righty, let me stop the share. Okay.
You know, there's just one, sorry, Caitlin, can you hear me?
Yeah.
Okay, there's just one, wait. Everyone take a second. There's just one question in the chat, so let me just ask it. If you have Medicare Advantage plan, will it just roll over, or do you have to re-enroll every year?
Unless your plan is notifying you that it's terminating for the following year. For instance, there are some plans that will notify you during this time. They notify you in September, hey, our plan's not going to be offered in January 2026. If you did not receive a notice and you got your annual notice of changes that says, here's the co-pays and changes for your plan for next year, you're going to be rolled into it for next year. If your plan is not terminating, you will be rolled into it for next year. If you're not happy with those changes, then this would be the time to enroll in something else, and then that new plan you enroll in would take effect January 1st. But if you don't do anything and the plan's not leaving, you're just gonna roll into it for next year.
Okay.
Okay.
I'm gonna swap
Okay.
microphones for you, because now if anybody you're gonna wait for me. I'm gonna bring the mic over so this way everybody can hear the question. I need your thing out of your pocket, and that should be working. Go ahead and just.
Yep.
Okay, so I think, all right, Bernice, I'll start with you.
So I see another question I'm just gonna answer. Suppose you are, so again, the 6 months of moving to a new state has nothing to do. The 6-month open enrollment period is only applicable to if you are new to Medicare Part B. In those states, you have a 6-month window to get a Medicare supplement plan without any health questions asked. If you're moving to New Jersey, then you may qualify because you're leaving your area, your service area, you may qualify for a guaranteed issue exception in the state of New Jersey, but it's only gonna be for like Plan G, for instance. So it's not, that's 6-month open enrollment period in states like New Jersey, Pennsylvania is only applicable to if you're new to Medicare, Part B, Part A and B, you have 6-month window to get a Medicare supplement plan without any health questions asked. After that window has ended, you are subject to what's called medical underwriting, where they ask who your doctors are, what medications you're taking, and if you don't meet their criteria, they don't have to accept you. We don't do that in the state of New York, but New Jersey does. States like New Jersey do. Yes, we're gonna, I think we recorded this, right, Barbara?
Yeah, it's still
Okay.
recording.
It's still
Let's,
recorded.
let's take questions from the audience.
All right.
I am, like so many people, bothered by scammers. I'm hearing impaired.
Okay.
Could you repeat the magic phrases to use to get them to hang up?
You got it. So, if you are being harassed on the phone by telemarketers, which my mother, as I've said, my mother's even harassed, and they say, my mother will say, my daughter knows all about Medicare. And they go, well, I know who your daughter is. But they don't know me, but they'll say anything. Ask them for what's called their NPN, National Producer Number. It's their insurance license. What is your national producer number? Also ask them, who is your FMO, which means Field Marketing Organization, or upline, which means, a lot of the time they're working for some type of higher up organization that is paying for all this marketing, that, where people are getting solicited. So ask those questions. You can even say, I'm telling you, you can even say, I work for Medicare, I work for CMS. You can even say that, or I'm a secret shopper. But I will tell you, I've had clients do it, and they said to me, Caitlin, the calls have really went down. Because they maybe, they'll update you, oh, don't call this person. So that's one of the ways to stop it. I know they're trying to stop it, but it is hard.
Okay.
Okay. Yep.
Thank you so much for your presentation.
Oh, you're
I'd
welcome.
like to know what oversight there is on these companies for charging what they charge. Is there any oversight from
Oh,
our government that
There
does
is.
that?
Oh, yeah, I mean, Medicare, you guys have rights under Medicare. Now, if you're not happy with the rate of your supplement plans, your Medigap plans, you can contact the New York State Department of Financial Services to stress what your complaints. You can complain to them, your elected officials. As far as the drug plans and Medicare Advantage is concerned, Medicare, CMS, Center for Medicare, Medicaid Services, is the one that oversees these plans. So for instance, let's say an Advantage plan says your doctor's in the network, you looked it up, everything was validated, and then you go to see that doctor, and all of a sudden the Advantage plan tells you, no, you gotta pay the full cost, because this doctor's not in network. Well, you have rights under traditional Medicare. You could file a complaint with, and say, no, their network says this doctor's in the network. You can always file a grievance with Medicare if you're not happy with how an insurance company is conducting themselves. You have that right, okay?
I think I saw it. And
Yeah.
over here.
Just a question about how to get your help.
Mm-hmm.
Do you come here, like if I said to you, I need help?
Yeah, so I come
have
here.
United Health Day. They're not gonna be covered by New York First.
Okay.
They told me very politely, they'll help me find my doctors. I said, no, you can help me find you, sure. Keeping the doctor.
You want to keep the doctor. So okay, yes, I meet with people here. Barbara will tell you I was in the office today, so we can definitely talk, and I'm happy to talk to you and meet with you.
Where do people go to, they wanna know, they wanna schedule an appointment with you? Who do we go to this, schedule?
Usually either me, I know Gigi was getting some calls, but you can, I don't know if Gigi's still doing it, I know she's busy, but you can contact me if you want. Shoot me an email, or you can call my number, 347-518-290, you got it? Okay. Yeah.
Back there, then I'll come over.
Thank you for the lecture. Basically, you just answered my question. I'm a lost puppy. I have no idea what I want in January, so I can call you and set up an appointment.
Sure, you absolutely can.
Fabulous, thank you.
You're welcome.
Okay. All right, let me go. Thank you. We're good.
So is there any questions here? I hope I answered some your questions. I know this information is, yep, got a question right here.
Okay, oh, hold on, I think she was next. And
Okay.
then- Okay, go ahead.
I don't know that much about it, anything. I only know that every time that I have an appointment, I have to pay $50 before I fill it out.
That's a copay.
Every time. I don't know what it is.
You're probably on an Advantage plan likely.
Yeah?
Yeah.
Okay.
That's a yeah, specialist copay you're paying, or is it?
They asking me if you had a Medicaid because I don't have that service that other people are getting.
Right.
But I don't know, that's what I.
Yeah, I'd have to look at your plan to tell you what you're paying, so. Mm-hmm.
Who was next? Okay, coming.
Now, some of you, you'll know, I've looked at your plans and I've said, stay where you are, don't change a darn thing, you know, so.
And I could go back to that first question in regards to the scammers. If you would ask them what their MP number is there something we should look for? Because they might blow their number.
Yeah,
Is
it's,
there something like it starts with, you always start with a C?
no, it's NPI always, like, for instance, it's NPN, I'm sorry, it's National Producer Number. My number is 189134667. It's usually 8 digits always, no matter what state they're in, actually. Yep, 8-digit number. Oh, you're welcome. You got it. Thank you. Any other questions? Oh, we got one over here.
Okay, I'm coming. Diane, that's you? Okay, and then you're next.
I hope this is correct. You had mentioned, there's a standard rate, for traditional insurance, in New York State. And you mentioned that you needed to be paid, you needed to have been under your employer's, coverage, for 10 years. What if you were short of 10 years?
No, that's not in New York State. That's a federal guideline. So that's talking about Medicare Part A hospital. Most people do not pay anything for Medicare Part A as in premium. You don't pay anything. Most of the people do not pay for it. But if they did not contribute, if they didn't contribute and they worked less than 40 quarters, which is 10 years, Part A has a premium of up to $600 a month. Yep. Very expensive. But you don't worry, you're not paying. I checked.
We have a question online.
Sure.
Does Medigap and prescription and dental roll over each year, or do you have to re-enroll? It's the same kind of question.
No, so Medigap plans, if the plan's not being terminated and nothing is changing, your Medigap plan is guaranteed renewable as long as you are paying your premium every month. And your prescription plan, same thing, only if the prescription plan is being terminated or you make a plan change. So if you don't re-enroll in anything and you don't get notification of any changes or cancellations, you're just gonna continue to roll into the plan. Okay,
Okay, we question over here.
sure.
Yes, besides of thank you very much for the Katie's professionalism.
Oh, my pleasure.
She explained, I really recommend her in your attention because she had me into very, very important and issues. I couldn't solve myself, and she was our soul and passion to help us with my husband. And thank you so much in front of everybody. And
Oh,
I recommend you, your attention.
thank you, Katerina. Thank you. You're the
We
best.
all recommend you.
Oh,
There's another question here. What are your thoughts on high deductible Plan G for Medicap? What are your thoughts?
I think in New York it can make sense if you're one of those people that's like, you know what, I don't want the Medicare Advantage plan. I'm gonna do a high deductible Medigap plan, like high deductible G. I think it may make sense, you know, they're affordable on the front end and you're basically capped with a maximum out of pocket. So I think that they're less, they do get premium increases, make no mistake, even the high deductibles are going up a lot in New York, but I do find that their premium increases are less dramatic because you don't get first dollar coverage, you have a deductible, and it basically is a maximum out of pocket. So if you're gonna do a high deductible Medigap plan, and I actually like the concept, because you're basically paying as you go, you're 20%, and then you're basically capped at that deductible. So I call it, it's All my clients who are accountants or understand math, they're always on the high deductible. They like it. Yes.
Sorry, quick question. I was told someplace I'm interested in going that I should get a community Medicare plan. What is that?
Community Medicaid? What?
Yeah, Medicare.
Community Medicare, I think that's just it's a terminology for different Advantage plans, but community Medicare,
Is there a community Medicaid?
no, it's community Medicaid, not community Medicare. So community Medicaid, just so we know, just to make it clear, traditional Medicare does not pay for custodial long-term care. They don't pay for assisted living facilities. They don't cover it. But community Medicaid may cover custodial home care services or custodial long-term care services and possibly assisted living facilities and nursing homes. That's community, yeah.
This is an assisted living, so
You-
how does one get this plan?
So it's not a plan, you need to actually get on Medicaid. You would likely need to go to a Medicaid planner or
Well,
a,
I have Medicaid,
oh, you do?
but they told me I had to get community something.
Yeah, that's something you would need to talk to the social worker about, yeah.
The
Mhm.
assisted living.
Right, I think they have to assess you, there's a whole process with that, yeah. That's more a social worker kind of question, yeah. Mhm.
Caitlin, can you repeat your phone number so I can put it in the chat?
Sure thing, it is 347-518-2902.
That's correct.
I have some questions in the chat. Someone said, are there monthly charges for Medicare Part D plan? Yes, there are. For the most, in New York and pretty much every other state, there is a premium for Medicare Part D, specifically standalone Part D. If you're on a Medicare Advantage plan, it may have the drug coverage built in, where you don't have to pay a premium. But if you're doing a Medigap plan with a standalone drug plan, you will have a premium pretty much most of the time, okay? Yep. All my information's there. Any other questions?
I have Medicare.
I'm sorry, Barbara's
Okay, who's there? Okay.
right over here.
Hold on, let me just, so everybody can hear you.
I have United Healthcare AARP. What did
Yep.
you say about Columbia?
So if you're on a Medicare Advantage plan, which is like HMO, PPO, then yeah. Yeah, if you're on Plan N, G, or F with AARP, which I don't know which one you have, then you can go to Columbia Presbyterian because Medicare, traditional Medicare is your network, not United Healthcare. Now, I'm gonna warn you though, you're gonna run into billing, sometimes the girls at the front desk or whoever works at the front desk does not know this and will say, oh, we don't take United Healthcare anymore. You have to be very firm. No, traditional Medicare is my network. My Medicare is the primary. United Healthcare is just there to pick up what my Medicare doesn't pay for. That's your network, traditional Medicare.
What
So
is
let
the
them-
deal with Columbia?
I know when negotiations are up, this is what I tell people, usually right around every 5 years is when these major medical systems and hospitals are negotiating with, especially managed care organizations, Advantage plans. At the end of the day, the insurance company's trying to pay the lowest amount possible that they can, right, to the providers, and the providers are trying to get the most money they can get paid. There's been a lot in the news about United Healthcare, as many of you may know. There's been some, obviously not some flattering news in the headlines, and I think, they just could not come to an agreement, and so New York Presbyterian pulled out. We saw this with Montefiore at one point, but it does happen sometimes. They're unable to reach an agreement, and they're out of the network, yeah.
I had that with Mount Sinai. They sent us a note saying we're dropping United.
Yep.
You have to change the VNS.
Yeah, it
And
happens.
then by the end of the year, they said, oops, we got a number we liked.
Yeah, it happens. That's happened too, where, just so you know, with the Advantage plans, when they are negotiating, they have to, as far as Medicare compliance, alert you of the worst case scenario. Oops, sorry. Meaning that they have to say to you, people will, my clients will tell you this, if there's anyone in the audience, Aetna was negotiating with Columbia Presbyterian in March of 2024. Right? All my clients got a letter that said Aetna will not be in network with New York Presbyterian starting April 1st, 2024. Of course, I'm having a stress panic attack because I know those letters make everything sound so finalized. But when they're negotiating and still negotiating, as far as Medicare is concerned, they're not in agreement yet. They're going to be out of network. But it's part of compliance. What ended up happening is at the 11th hour, I kid you not, on March 31st, they came to an agreement and now they remained in the network. So Yeah, no problem.
It's like a lot of the negotiations with the cable companies and ESPN and
Yeah.
various things. It is a bit of a negotiating ploy.
Yes, it is, and it's also to shake it up sometimes. Yep, I mean, New York Presbyterian will post right on there. We're not going to be a network, just to get exactly, yes. Are there any other questions? Yeah.
Discussing with the agent from United Healthcare.
Yeah, you would.
They said that for Advantage Plan, they said that the premiums are not higher than, not that the premiums are not higher than $20.
It depends on the plan.
I mean the copays.
On the Advantage plans, the copays?
That's what he said, I think.
No, he was definitely talking about Plan N to you, which is another Medigap plan where the medical copays to a doctor. No, Advantage plans have varying copays. They're a completely different animal than what you have. Yeah, no, I think he was talking about a different Medigap plan, which would be N. N is lower than Plan G. It's a Medigap plan, and they have an up to $20 copay when you go to the doctor. He wasn't talking about Advantage plans. Yeah.
As you referred to before, like Medicare and other alternative health insurance coverage, do they also have the same access to the network of doctors?
Under a Medigap?
Yes.
Traditional.
Other that Medicare has.
No, Medigap has no network. Medicare Advantage plans have a network. Medicare Advantage plans have a network, not Medigap plans. Medicare Advantage plan can have a very different network. In my opinion, if you're on traditional Medicare, with a Medigap, you're going to have more access to doctors than a Medicare Advantage plan, for the most part. Yeah.
In the example you gave about United Healthcare not being accepted in New York Presbyterian, you're to inform them that Medicare is your primary.
Yes.
But does that leave you with the 20%?
No, because
No,
you would not be stuck with the 20%. United Healthcare is not the network. A lot of people don't understand. Supplement plan it's not managed care. It is not managed care. It doesn't have network regulate. There's no network restrictions at all. Traditional Medicare pays 80%, and your supplement is there to pick up the 20%, right, after you've reached the deductible. They cannot, by law, deny United Healthcare, because United Healthcare is just there to pick up what Medicare doesn't pay for. It has no say, so, yeah, you gotta make it very clear. Traditional Medicare is my network, and if they disagree with it, say you can call the federal government, 1-800-Medicare on the back of my red, white, and blue card, and they will tell you the same thing. Yeah, if sometimes there's lack of education, and you will run into it, so you're gonna have to educate some of your providers, if you run into that. Traditional Medicare is the network when you're on a supplement. Yes, David?
If I can make a suggestion, I think anybody who tried to write this all down, her email address and her phone number.
Just call me.
Well, but get a card from her.
Mm-hmm.
It's on the pen, by the way.
Or on the pen.
On the pen, but it doesn't have the email address.
Yes,
So,
David
Check
knows.
with her on that. This is one extra card.
Oh, thank you, David. You're welcome. Thank you. You're welcome. Anyone else have questions? Good to see you.
Same here.
Have you been?
Good. How are you doing?
I'm doing much better. Thank you for checking in.
Okay, I'm gonna shut
Thank you, everybody.
Are you free next week sometime?
Yeah, yeah, sure.
I can follow up. I don't want to bother you.
Yeah. Yeah, shoot
Good
me
to see
an
you.
email.
Glad
Good to
you're
see
doing
you
well.
too, David. Thank you, thank you. Do I have what'd you say, a card? Sure do.
Is Columbia being taken over by a different company?
No, they're just, ugly.
Because a lot of doctors are leaving.
Yes, they are. Well, it's.
So I'm staying with everything I have.
We were looking at the, there was.
I got a year's worth of medicine from the hospital.
Yeah, stock up. I mean, the network for next year is the most important thing. That's really.
Should I stock up 2 years worth?
Might as
Please
well.
repeat your phone number.
Everything going. Hi, good to see you. I'll be in touch with you. All right.